Hello. Yeah, we're about to begin. So this week's session is going to be on the spinal cord, and we're going to be taking a look at two things here. We're going to be looking at the basic anatomy and some pathology, specifically back pain. So an overview, we're going to do the spinal cord itself, anatomy, segmental variation. We'll also look at the meninges, the different layers, and the blood supply of the spinal cord. We will briefly touch upon dermatomes, but that's going to be in a separate video. But key things here is going to be the spinal cord pathology, which is non-specific back pain, lumbar disc prolapse, and spinal disease red flags, and how all of these relate to the anatomy, and how we can use our knowledge of anatomy to understand these diseases and how to treat them. And we will of course also do some sample questions. And you're feel free to write questions into the live chat or into the document, and I'll address them as we go, or even towards the end. So it's up to you guys. As soon as you have a question, don't be free to ask. So moving onwards. So we'll start with the spinal cord here. And what we see here is that there's four separate parts of it. So we'll have the cervical, the thoracic, the lumbar, and the sacral, and then there's a small segment which is the coccygeal part. Now it's part of the central nervous system. It is the caudal part of the central nervous system. It's continuous with the brainstem, so the brain being the cranial part, and we have several segments. So we have cervical, thoracic, lumbar, sacral, and coccygeal. And all these segments here, they have different functions, and they're all depending on the levels they come from. Now moving onwards, we have the passage of the nerves. I apologize for the mistake, this should be 31, not 38, so it's 31 segments. And the nerves pass through the intervertebral foramen. Now all nerves do this, and the intervertebral foramen are in between the vertebrae. It's a little gap where the nerves can pass, as you can see here. Now C1 to C7 all pass above. So those are all above, right? All above. Whereas C8 onwards, all of the ones for C8 onwards are the nerves pass below the vertebra. So we can see this here a little bit, but they go above the vertebra and then C8 goes below. The reason for this is because we have only 7 cervical vertebrae, but we have 8 cervical segments of the spinal cord. So in order to accommodate this, one has to go below. And this is because of the anatomy here. So we have the atlas, we have the axis, atlas holding up the axis, and essentially they all go above except for C8, which starts with below, then every other one is also below. And this goes all the way down to the coccygeal. So we'll look a little bit about the spinal cord segment. So this is quite common, you might be asked questions about this. So it's a cross-section, and what we're looking for here is the different parts. So we have the funiculus, which is the white matter, which appears dark. So it's the white matter, and it's the white matter because it has bundles of axons. Whereas the horns themselves, which is the gray matter, but they're depicted as white here, they contain the cells and the neurons. So what we have here is a division between the gray matter and the white matter. Just like we have in the brain, it's also present in the spinal cord. Now the dorsal aspects, so that's the ones in the back here, they come from a different segment than the ventral aspects. And if we look at it here, it's because of the embryology. And the alar plate is the dorsal part of the neural tube. And all the cells which are part of the alar plate, they become the dorsal funiculus and dorsal horns. Now what does this mean? So this means that the dorsal parts, they all receive sensory inputs, whereas the ventral parts, which are or anterior, which come from the basal plate, they receive or they give out motor outputs. So that's the first fundamental division between the spinal cord segments. It's the dorsal and the ventral. Now we also have something called the lateral horns here, and the lateral horns are specific to the thoracic and lumbar regions. And the reason they're here is because the thoracic and lumbar regions provide autonomic signals as well. So these are autonomic fibers, whereas the cervical, thoracic, and sacral, the cervical and sacral ones, they do not have a lateral horn because they have no autonomic components. So let's look at the spinal cord a little bit further. So this is something we should all be familiar with. So we have the dorsal root, ventral horn, dorsal horn. And what we see here is that the anterior root, or the ventral root, it has motor neurons. So that's depicted here in red. So that's motor neurons. So that's called an efferent. So an efferent means that it's going out. So if it's out, it's efferent. So think as an exit. But if it's coming in, that's afferent. So afferent and efferent. So it's an efferent motor neurons. And the cell bodies are found in the gray matter and the cells themselves, whereas the axons are found in the white matter. And that makes sense. And for the motor neurons, you can see it right here, right there, that is a cell body in the neuron there, in the horn. And they all contain efferent fibers. Now the dorsal root is a little bit different. It contains the nerve cell bodies in the dorsal root ganglion, so it's a specific organ here. And this is where you have the body of the cell. And these are all efferent, so these are signals coming into the spinal cord. And basically the role of this dorsal root ganglion is to contain these nerve cell bodies. And what that means is that when they contain these nerve cell bodies, it ensures that only afferent neurons come through there. Now, as you can see, the neuron, when the nerves go together, they form a nerve here which has both afferent and efferent. So in one nerve you'll have afferent and efferent, but they come to the cord separately. And what they are, they're something called pseudo-unipolar. So they're sort of unipolar because they don't synapse at the ganglion, as many times happens at a ganglion. The purpose of a ganglion is for synapse. This is the exception here. So there's something called pseudo-unipolar because they don't synapse at the ganglion and they're so one way. Now you will also have a relay neuron, which will be found here. And these are a very complex system of it's gate control theory. It's all these other nerves, all these other signaling pathways which occur in between. And this is where you would find them. So you have your afferent coming in, relay, and then efferent coming out. So to summarize all this, anterior or the ventral root is motor neurons, posterior or dorsal root is sensory motor neurons, and the dorsal root ganglion is where the nerve cell bodies of the afferent fibers are found. So that's like a summary of the spinal cord segment. So the next thing we're going to look into is segmental variation. We've touched a little bit upon this already. So the cervical looks like this. It's a little bit flatter, it's a little bit smaller. But as you can see, there's no lateral horns, right? And what we see here is that it innervates the hands, it innervates the arms, it innervates the upper limbs, and also the neck. And what we can also see here is that the dorsal and ventral horns there's different size, they're slightly bigger. The ventral horns have a higher sensory input because it's much more sensitive. That's why they're longer here and bigger. And the cervical parts, they're used for fine muscle control. So if you can imagine, it's your hands, it's some fine motor activity. Whereas if you compare it to the thoracic, so thoracic is much more smaller. It looks like a butterfly, and you can even see the lateral horns here, slightly poking out. So the lateral horns there are, they have smaller dorsal ventral horns. That's the first thing, because it's fewer sensory inputs. So your torso and your back, the sensitivity of those parts is much smaller than the sensitivity in, let's say, your hands. And the reason for this is because of the shape of the thoracic segments of the spinal cord. Now, what this enables us is that we have larger muscles that are in control. So the size of and the thickness of the ventral horns and dorsal horns is quite similar. And they're smaller because it's bigger muscles which require more power. So with our back, we can make much more stronger inputs than with our upper body. That's one of the reasons we have the division there. Or with our limbs. And these muscles are different. You need different activation of fibers, and you need a stronger activation. That's what the thoracic is smaller. Once again, when we look at the lumbar, we can see the lumbar here. It's much bigger. Both ventral and the dorsal horns are much bigger. This is your sensory, this is your legs, so your legs are innervated, just like with the cervical, and it's your limbs. Now, if we look at the sacral is very tiny, and it almost looks like a cross-section of an esophagus. It looks like a small butterfly. It's quite obvious. So the sacral, towards the end, when you reach the sacrum, the thickness gets smaller, as we saw. So it's quite thick at the lumbar, spinal, thoracic, and it gets really thin at the sacral. And then you have these hairs, which we'll get onto later on. So then you have like individual nerve fibers. Now the sacral region, that's around the perineum, and the sacral region is a very small area. Still quite sensitive, but a very small area. So to summarize, the cervical lumbar have a larger dorsal and ventral horns. They're much bigger, take up more space. The function is it's limb innervation, high sensory input, and small muscles, whereas the thoracic and sacral, they're involved in the buttocks, they're involved in the function of the legs. That's for the lumbar. For the thoracic and sacral, that's your back, and other different muscles, which are the perineum, which require fewer sensory inputs, and it's the axial muscles, the ones near the skeleton. The lateral horns, which I alluded to before, it's for thoracic and lumbar, and that's because they have the cell bodies of the sympathetic nervous system. So that's the unique feature for thoracic and lumbar, but other than that, this is how they're grouped together. Moving on, so I'll talk next about the meninges, and I think this can be quite confusing because it's very similar to the brain. So I'm also going to talk about the differences between in the brain and in the skull and in the spinal cord. So this is something we should all be familiar with. It's the vertebrae with the spinal cord, and we also have the nerves coming here. We have the ganglia, the dorsal root ganglia, with the bones. Now the space that's just there's three main layers. So you have the dura mater, arachnoid mater, and the pia mater. Dura mater is the one that's closest to the bone. Arachnoid mater is just beneath that, and pia mater is very close to the actual nerve. So if you think about it, this is from outside in. We also have three different spaces. So we have something called an epidural space, which is between the dura mater and the vertebrae. And so that's between the bone and the dura. We then have the subdural space, which is between the arachnoid mater and the dura mater. So if we can imagine, there's the different layers. If we have bone here, that's bone. We have dura here, and then we have arachnoid and pia mater. So it's the spaces in between. We also have something called the subarachnoid space. So that would be here, subarachnoid. A subarachnoid space between the pia mater and the arachnoid mater. And this is the only space that's an actual space, and it's filled with CSF. These first two are called potential spaces. So fluid is normally not there. However, if you have certain conditions like bleeding, trauma, then blood can leak into these spaces and can cause problems, can increase pressure. Much similarly like it's in the brain. If it goes into epidural space, it will be an epidural hematoma, or extradural hematoma. If it's under, it's a subdural hematoma, and if it's subarachnoid space, it's a subarachnoid hematoma. It's less common in the spinal cord because of the protection of the body, and it's much smaller. But you can imagine that these different spaces can be quite important when you have inflammation. If you've watched my rotator cuff videos, it's all about narrow space. The bone doesn't allow for much expansion. It's meant to protect there. And if we have a narrow space, and there's an inflammation in this narrow space, or any bleeding, well, it's nowhere to go, and it will cause pressure and it will cause symptoms. And we'll get into that a little bit later. Now, there's one key thing I want to talk about here, which is the difference between the spine and in the skull. So in the spine, you have only one meningeal layer, so that's only one dural layer, whereas in the skull, you have a periosteal and a meningeal layer. So what does this mean? So the periosteal layer would be the layer surrounding the skull, so it's in the inside of the skull, whereas the dural layer would be the one just surrounding the brain or the nervous tissue. But in the spine, we have only the dural layer, which surrounds the neurological tissue. So yeah, it's epidural space, subdural space, subarachnoid space. And the order of from outside to in is dura mater, arachnoid mater, and pia mater. And that's basically all. That's how I visualize it. It's in a simple way. If you're interested, you can go into more depth. But I think keeping these key concepts, thinking about the three main layers, three main spaces, is a good way to memorize this and to think about it. And the spaces are always the ones in between. So this is one space, that's one space, and the one between the dura mater and the bone is another space. So if you understand the anatomy, you can figure out the spaces. And the epidural and subdural space are potential spaces, which means that that no tissue or no fluid should be there in a normal situation. It's just the different layers of the tissue. Now, subarachnoid space is the one which is an actual space which is filled with CSF. So we're going to go talk briefly about the arterial supply and the venous supply. So what I want to show here is so we're talking about the arterial supply. So there's an anterior spinal artery, there's a posterior spinal artery, and then you have radicular arteries. Now the anterior spinal artery is quite simple. It comes anteriorly to the anterior part. So we would cover this part here. So the anterior part of the horn. Yeah. Then you have the two posterior spinal arteries which run in the back. So they come from the back there. Right? You have radicular arteries which come from the aorta, and they merge through the posterior intercostal arteries. And what this essentially does is that you have, as the aorta goes up, and it runs very closely to the spinal cord, it can directly feed off little branches of arteries. These are called radicular arteries because they radiculate, so they go in a radius out. Now the venous blood supply is quite complex, but we'll simplify here. You have something called the busted venous plexus, or the internal vertebral plexus. It's surrounded in this fatty layer, in this extradural fatty layer. And what this does is that it drains blood and communicates freely with the veins of the brain, abdomen, and pelvis. So it connects the venous drainage with everything else in the body. The key thing here is no valves, and there's a connection. So if you have a cancers can get lodged in here. And if you have no valves, well, that means you can just get lodged there and stay there and grow. So metastases are very important in the Boston venous plexus. The epidural venous plexus is contained within the epidural space, and that will be somewhere here. And then you have the dural venous sinus, which is blood and CSF from the brain and the spinal cord. They empty into the internal jugular vein, which goes towards the heart. You also have some spinal veins, which are minor veins here, and they run alongside the spinal cord, much like the arteries do. And if we move on to the next question here, so this is where the aorta, these are the radicular arteries, and as you can see, they go directly off the aorta and into the spinal cord. Now, here is an important artery. It's called the Artery of Adamkiewicz, and the reason it's important is because it supplies the anterior 2/3 of the spinal cord. So if we're thinking about anterior 2/3, that's our little spinal cord here, you know. It supplies this part here, anterior 2/3. So that's the blood supply of the anterior spinal artery. Now, the anterior spinal artery, it originates from the left posterior intercostal artery in 70% of people. But what's important here is that there's a little branch spot here. And this occurs roughly at around T8. And the Artery of Adamkiewicz, it's an anastomosis with the anterior spinal artery. And it supplies all the way from the T8 to conus medullaris, which is a long way. Now, if you have ischemic injury, right, or if you have any sort of damage to the spinal cord because of this artery, if you're operating on the aorta, well, suddenly from T8 and T9 downwards, you have no longer any innervation, and it's on the anterior side. So what this can result in is loss of continence, impaired motor function in legs, and spasticity. So you become basically the worst case scenario is that you're incontinent and you're paralyzed, and the better aspect of that is that you have difficulty containing your urine, and you have some weakness in your legs. So this is a very important, and it's especially important in operations near the aorta. So what they need to do is they need to identify this artery when you're treating an aortic aneurysm, and so that you prevent any damage. And the key level here is at T8 of the spinal cord, which is T9 of the vertebra. And from there on, you have to be careful that nothing is getting occluded. And the branches are the posterior intercostal artery, and it anastomoses with the anterior spinal artery. So it's anterior spinal artery plus the posterior intercostal at T9. And this is like one of those fun facts that you just sort of have to memorize, but they're very important when it comes to ischemic changes in spinal cord. So I'll talk briefly about dermatomes. This is more of a visualization exercise. So I've always found dermatomes to be very tricky. And the way the dermatomes are supposed to be, you have to think of it as a four-legged animal. So they're quite linear towards the spine. So you have a cervical, which goes all the way halfway through your hand. Then you have T1, T2, all the way to around your waist, that's L1. And then you have S1, S2, S3, S4 from the bottom down. Now some key areas to remember would be T4 is the nipple, T7 is the xiphoid process, T10 is your belly button, and then you have S2, S3, S4, which control the perineum. You also have some sort of variations like the big toe, that would be S1. And yeah, I think this might be helpful to visualize. We will be making a future video on dermatomes and myotomes if that's what you guys find that's interesting, that's what you need content on. But I think this is an easier way to visualize dermatomes, because you have the man who's standing up from anterior and posterior, which can be quite difficult. But this is how the dermatomes act as if it were a four-legged animal. So as the spine changes, therefore the dermatomes as well. So the back area, or the posterior chain, if you will, is by the sacral nerves, and the sacral part of the spinal cord, lumbar, is the anterior portion, so that's your extension of your legs, and torso is T, so thoracic, and cervical is head till middle of your middle finger. So now we're going to talk about back pain. So non-specific back pain is a very common condition. It can become chronic. In the UK, it's roughly responsible for 14% of long-term disability. So it's a big deal. You know, if you have this pain, you can't work, and that costs man hours and inefficiencies, and people can get fired for that. So it has wider socioeconomic implications. but it's very common. It's everyone will have this at some point in their lives, back pain. It's that common. And the key symptoms are tension, pain, and stiffness. And you can categorize the causes into 5 categories. You can have mechanical, so this is the most common and often least serious. You can have inflammatory, so this could be an inflammation of the spine or an infection. So remember the dural spaces we talked about. You can get fluid there, or the CSF. You can get stuff growing in the CSF, and that can cause an infection. Or you can have an infection of the bone, which is called osteomyelitis. And if you have an infection there, that can spill out everywhere else, and you can cause back pain. It would be red and inflamed. It would be very painful. You can have inflammatory conditions such as ankylosing spondylitis and sarcoileitis, which would be a little bit lower down. And that's just the joints itself being inflamed. It's a type of inflammatory arthritis. We have metabolic ones. So this is your osteoporosis, which can cause fractures. So this is, think about elderly women, women in their 70s or 60s, if it's early onset osteoporosis. Or osteomalacia, this would be an insufficiency of the bones. So the bones are weak because of nutrient requirements. Most serious would be neoplastic. So you can have metastasis, so cancers that go to the bone. You can have multiple myeloma, which is ones in the bone. Or you can have a primary bone tumor, which is very uncommon, but that can also cause bone pain. If you think metastasis, a classic scenario is an old man in his 70s or 80s, smoker, has bladder cancer, and it metastasizes to his back. You can also get referred pain, which could be pain in a different part of the body, and it's hitting you there. You could have kidneys, so you can have kidney stones, that can hurt in your back, so that's called flank pain. So that's also a cause of referred pain. Now the mechanical pain, it's usually short-lived, starts suddenly, and can be recurrent. Most commonly it's trauma, so you fall. Could be muscular or ligamentous pain, so that's you lifting a lot. Could be postural back pain, so it's either you're slouched, so poor posture, or you could be pregnant. So women, when they're pregnant, their lumbar spines, they're slightly thicker than in men, and that's so that you can allow curvature of the spine when they are pregnant and they have bigger bellies. So it's to offset the load. So you get back pain from that. There's something called lumbar spondylosis, which is just degeneration of the intervertebral discs. So you have my primitive drawing here. So that's one of your vertebrae, and then you also have an attachment like this, and that will be your IVD, your intervertebral disc. Now this intervertebral disc can degenerate, and not only that, it's also the vertebral bodies and the lumbar vertebral joints. Now if all this happens, you can get pain, and this comes with old age, comes with overuse. You can have something called facet joint syndrome, which is where you get osteoarthritis of the facet joints, which are the ones that hold the spinal cord together and allow it to move. Sorry, they hold the spine together and allows it to move. And when this happens, it's very painful. There's not really much you can do other than spinal surgery to sort of remove it and to clear the area. We can also have acute lumbar disc prolapse, and then there's the red flag signs, which we talked about afterwards. So the next thing we're going to talk about is the acute lumbar disc prolapse. So this can cause pain, and it's very uncomfortable pain. If you know anyone who's had this, it's very uncomfortable, and there's just nothing you can really do about it. And it feels like it feels very uncomfortable. So, but these patients will be in a lot of pain. But there's a certain way that this works. So the disc itself, it's made up of this stuff called nucleus pulposus. So the nucleus pulposus is what's found inside the disc. So that's the stuff here. That's nucleus pulposus. Now what can happen is that it can extrude, right? It can extrude through the annulus fibrosus, which is the fibrous outer region of the disc. And when this happens, it can go beyond the structural limits. What that means, it goes beyond this little enclosed circle. Now there can be many causes for this. You can have trauma, you can have aging, degeneration, but what happens is that it somehow just pops out, and this herniation it's posterolaterally is most common because that's a weak point structurally. Because if you put pressure, you have a gap there, and it usually penetrates through here, extrudes, and pinches a nerve. Now, when this happens, when you have this pinching of the nerve root, you get pain which is in relevance to that nerve root. And when this happens, this posterior protrusion, it's towards the intervertebral foramen, which is just where the nerve passes. So a number of things can cause this. You can be lifting in a flexed position, right? So you're not engaging your buttocks properly to lift something. You could slip. This happens often. You can slip and suddenly just move your back in a weird way. You fall on your back or on your buttocks. This can cause trauma there. Or in very old people, let's say they try to suppress a sneeze, especially now, or suppress a cough, because with COVID, or they have masks, they try to suppress a sneeze or a cough. This increases their pressure, and they would sneeze, and suddenly they would throw their back out. In elderly people, I've seen a patient who laughed too much. Something funny was told to them, and suddenly they felt a pain in their back, and it was a prolapse disc. So any sort of sudden change in pressures, especially in very frail and elderly people, can cause this. Now, speaking about elderly and frail, you have aging. So the nucleus pulposus, this gooey inside, right, that's meant to sort of upholster everything, that cushions the pressure from the spine, can sometimes just dry out. And once it dries out, it loses its elasticity. And with this loss of elasticity, you just have a disc that's willing to protrude. And if there's a weak point, like we said before, in the posterolateral area, it will just squeeze through there. Now, the cervical and lumbar regions are most often involved in IVD herniations. And this is because you have the greatest bending. So it's the lordosis and the neck and in the back. And what happens here is that it's the greatest bending of the vertebral column, especially in the lumbar part. You also have a lot of weight bearing there, and in the elderly population, you'll have a lot of people hunched over because their back is not as good anymore. Now, it's a very load bearing area. A lot of people, let's say you lift something incorrectly and you're frail and you're predisposed, all of this together can give you an acute lumbar disc prolapse. You could also have degenerative disorders of the spine, so this could be from osteoporosis, this could be past fractures, anything that disrupts the stability and integrity of the spine. And when all of this happens, you will get this prolapse disc. And usually they present with diffuse unilateral pain and radiates to the buttocks. So the reason it radiates to the buttocks is because of this nerve root pain. So let's say this is around the lumbar level, so the lumbar spine creates the sciatic nerve, which is the thickest nerve in the body that runs down our leg. And suddenly, it's this thick nerve, you get a problem in the lumbar plexus, and all of a sudden you get this terrible radiating pain down the buttocks. And it worse when you try to bend over to pick up something or twist. So a lot of these patients, they will be unable to bend over and pick something up. That will be like a key sign. And it's usually diffuse pain, so they can't really pinpoint it. You would say it's all over the leg and it's unilateral. And some people might feel paresthesia, so it's like tingling. They might feel neurological signs in one leg or numbness. Or some will say that it's like excruciating pain, like someone's cutting into them. That might be a description as well. And yeah, if this happens below level L2, L3, it becomes a lower motor neuron lesion rather than upper motor neuron. And the reason for this is because the nerves themselves at L2, L3, the spinal cord sort of ends there, and it becomes, you have these hair-like projections from it, which are not usually linked to the spine. They're not that closely. I'll show you a picture of this afterwards. See what I mean? It will be in one of the questions. But yeah, if it's below that, it's a lower motor neuron lesion because it's affected the motor nerve. So red flag signs. So lower back pain is non-specific unless these things. So if you have a patient who's younger than 20, so like a child, or over 50, Now, people between ages 20 to 50 are likely to have mechanical back pain, and you just give analgesics and they'll feel better. You can also have, if there's persistent pain and a serious cause, so you could see a fracture. You think they might be an inflammatory condition. Let's say they have inflammation in their hips and suddenly their back is getting off. Or they're osteoporotic, so it's a metabolic cause. They had a hip fracture and suddenly their back's acting up, you know? Or it could be neoplastic. So let's say they have bladder cancer, you've treated that, but suddenly they develop back pain. Well, that means it's a metastasis. Now, if you have worse at night or in the morning, once again, inflammatory arthritis, infection, or even a spinal tumor. And if you are associated with other systemic illnesses, so fever and weight loss, that's another red flag, because that could be a cancer again. So there's saddle anesthesia, so that's when you feel numbness around the saddle region, like when you would be riding a horse. That's a key red flag, or which means there might be a surgical problem, or you might need to call neurosurgeons to fix this. Cauda equina syndrome, it's a numbness around the anus, fecal and urinary incontinence. Huge red flag. You want to call a neurosurgeon, get them down there and have them fix it. Or if you have persistent thoracic back pain, because in the thorax you don't usually have pain. It's not that much of a load-bearing joint, so it could be a tumor, it could be metastasis, it could be a pathological fracture. So if it's quite high up, that's also quite uncommon. Okay, question times. So this is some sample questions that I've created myself, other people in my year have created, or we've seen in exams that we're trying to reconstruct them. So first, it's nice and easy, a labeling question. So it's asking you to label the different structures. In a cadaver, we got these questions all the time. I think especially now with the fact that you didn't have labs in person, they might ask some of these questions to test your knowledge from if you've been looking through the labs and looking through the pictures. So I would highly recommend look through the labs, look through the pictures to understand these sorts of questions. So the first layer here, what are we looking at? Well, that's the dura mater, because it's so close to the bone, right? That's the dura mater right there. And it's just outside the bone. Next, what we have here is a little space. So that's between the dura mater and the bone, making it the epidural space. And as we see here, it's between the dural space and the arachnoid mater, which is a very vascular layer. And therefore that becomes the subarachnoid space. So we can easily derive these. It's not that tricky. But yeah, so dura mater, epidural space, subarachnoid space. I recommend looking at pictures like this. It really helps solidify the anatomical understanding, because A, you need to be able to visualize it, and B, as I explained before, it's how it applies in a person's pathology. So next thing, we're going to look at this very similar. So identify the following structures on the lumbar cistern. And so they gave you quite a good match here, so to say what's what. So this is what I was referring to before. We have the conus medullaris, which is the tip right here, between it's the end of the spinal cord basically. And this is where it's usually L2, L3, and that's why the nerves here, if you hit the nerves, it becomes not a spinal cord lesion, but a lower motor neuron lesion. We also have the cauda equina, which means the hair of the horse. And the anatomists who found this and took apart the spinal cord thought that the tail end of the spinal cord looks like a horse's tail, which it very much does. It's like these fine little fibers like a horse's tail. That's called cauda equina. We have also here this sheath. So that's the dura mater, so it's covering up the neurological tissue. So if it covers up the neuro tissue, it's always the dura mater. And moving onwards, we have the filum terminale. So the filum terminale is very important. It connects your spinal cord to the bottom of your skeleton. Without this, it would just be sort of hanging and levitating, so it's a very important structure. So I'm going to talk a little bit about the lumbar cistern. So here you have the cistern itself. It's the end of the cord, so the end of the spinal cord is here, and you have this little tail-like extension. Now, in the lower lumbar spinal canal, it becomes the subarachnoid space. The cistern is an enlargement of the subarachnoid space, and it's found within the dural sac. So the spinal cord ends, and you have all this subarachnoid space. All the red stuff here, that's your subarachnoid space. And within the subarachnoid space, you have these fine hairs called the cauda equina. Now, the contents within this lumbar cistern is CSF and nerve roots of the cauda equina. So if you want to take fluid, you know, you will go between L4, L5, or L3, L4. The reason is because you have these thin little hairs, and if you inject, you can just sort of move them around. You're not really going to hit the spinal cord. So if you were to go at L3, for example, or sorry, L1, right here, boom, you hit the cord, and that's bad. You just paralyze the person. Now, you can still paralyze someone if you go with the needle here, but it's much less likely. Here is an alternate picture. This is from Teach Me Anatomy, a very good website. And in this picture here, we have the conus medullaris, so it goes into a cone, right? And at the end of the spinal cord, usually L1 to L2. And it tapers off, and you get this long ligament right here towards the end, which goes towards the end of the dural sac. It's roughly 20 centimeters long, so roughly give or take 20 centimeters. And what it does, as I said before, it supports the spinal cord longitudinally, so it holds it in place. Without it, would just fly around. And as you can see here, so spinal cord ends here, the dural sac ends here, and then you have the filum terminale just attaching it to the bottom. And all the stuff here, they're not really showing this quite accurately in this diagram, but it's all filled with these lots of nerve fibers, which look like the end of the horse's tail. So that's why it's called the cauda equina. So this stuff here will be called cauda equina. Okay? Moving on. So this is a very common question. You'll get asked this by anesthetist in placement. You'll get asked this if you're on a surgical placement. You'll get asked this. You know, this question pops up all the time, so it's good to learn it now. It's what are the layers of the back that need to be penetrated for epidural injections, or just in general, layers of the back. Now, there's two steps for this. So initially, you want to identify something called the Tufier's line. Tufier's line is where it's a theoretical line, and it's the intersection between the superiliac crest, which is roughly L3, L4, and the spine. So it's when you have your superiliac crest and the spine, and what you do, you draw like an imaginary line, and that should roughly be L3, L4. And that's where you go with your epidurals, that's where you get CSF fluid, all that stuff. Now the layers of the skin, there is 5 of them. So you start with the skin itself, or fatty tissue, then skin. And then you go into, so you have the subcutaneous tissue. This is mostly fat. If you're doing this impractically, for people with a larger body habitus, this layer can be much thicker, and therefore you have to go a little bit further to reach the correct area. So you have subcutaneous tissue, you have supraspinous ligament, you have interspinous ligaments that go side to side, and then you have this thing called ligamentum flavum. So flavum means yellow, it's the yellow ligament. And this is the last thing you penetrate before you reach the canal. So that's the final thing you reach, and that's the final bit of resistance. You've been too far if you've hit bone, right? That can sometimes happen. That's pretty bad. But it's skin, subcutaneous tissue, infraspinous, interspinous ligament, and then ligamentum flavum. Supraspinous, it's because it goes from top to bottom, and interspinous because it goes from basically medial to anterior to posterior. So that's how you would answer that sort of question. Very key. This always comes up in exams, and if it doesn't come up this year, it'll come up in 3rd year, 4th year, 5th year as a doctor, right? So very important. And the needle you use, this came up in my exam in 2nd year. It's called a Tuohy needle. So it's pronounced 2A, but it's called a Tuohy needle, Tuohy, Tuohy needle. Okay, similar question. At what level would you conduct a spinal tap, and why would you do a spinal tap? So this is what a spinal tap looks like. It's when you're trying to usually collect a CSF, and you do this at L3, L4, or L4, L5. Once again, as we discussed before, it's to limit the damage and the chance of paralysis, and it's the safest part to enter the lumbar column. You also go this low because it's the lumbar cistern, there's less nerves, and you're less likely to damage something. Now there's two uses for this. So you have a diagnostic use, which means you withdraw, you measure the CSF, and by this you can either measure the CSF pressure, or you can just see in the CSF if there's blood, if you're looking for if there's a hematoma. Secondly, it has a therapeutic benefit. So this is your antibiotic administration, so ATB administration. So you can administer antibiotics directly through here if you have like a spinal infection, but it's also a route for chemotherapy. So you can use this as a route for chemotherapy. Spinal tap, very similar to an epidural. It's the same procedure, it's at the same level. So what are the features of cauda equina syndrome? I was meant to say cauda equina syndrome. So cauda equina syndrome, we have to focus on the anatomy here. It's the hairs here, it's from the conus medullaris down. And it's a neurological emergency. So you have three different types of problems here. You have sensory problems, motor, and autonomic. That's how I like to remember it with newer stuff. Sensory, you have low back pain. You would have bilateral sciatica. So that's the pain down the back of your leg. You would have saddle anesthesia. So that's within the saddle region. That's where you would like sit on a horse or sit on a saddle. You have motor weaknesses as well, which is your bilateral leg weakness. You would also have decreased, reduced sphincter tone, or the inability to contract the sphincter on a PR examination. And you would also have autonomic problems. So you would have urinary incontinence, you would have fecal incontinence, and yeah, it's a neurological emergency because there's some pressure pushing on this cauda equina. Something's wrong, something's harming this area here, and you want to get rid of that as soon as possible. It could be fluid, it could be a tumor. It could be a fracture, it could be a lot of things, but you want to get it sorted. And that's why it's an emergency. So which investigations may be useful in suspected cauda equina syndrome? So the answer to that is MRI of the spine. And I'm going to give you some pictures here to help visualize what the cauda equina syndrome could be. So pathology here, we have a tumor or something's not right here, it could be blood, but some sort of lesion. You don't have to know what it is, but you could say it's a lesion and it's pushing on to the spinal cord. You see how it's compressing it? That's not normal. That's not good. Here's another picture. So this is a much more invasive tumor. And once again, so it's different MRI images. We remember that water is white in tier 2. So this one would be T2 imaging. That would be normal. What we're looking at here is the spinal cord, and look how this is compressed. Yeah, that's clearly not normal, and you can see that this patient can clearly have problems with his legs, problem with defecation, problem with urination. So it's quite obvious here, but this is what you're looking for. MRI scan, it gives you the picture quality, it gives you the contrast, gives you everything you want to see to visualize these lesions. So cauda equina, you always give an MRI. And that brings us towards the end of the presentation. The video will be replayable after the session. Do leave us feedback, like it, all that sort of stuff. I'll be posting a poll to see what you guys want to see next. And if you have any questions, now is the time. Just ask me, either for the lecture itself or the content here, or about the spinal cord in general. Anything I left out, anything that wasn't clear, just type your questions in, either the Google Doc or through the live chat here. So just put the questions in. I'll repost the link if it's not available here. The link is here. Feel free to ask questions. If there are no questions, that's good. It's okay. If any new questions do come up, just write them in here. Write them into the Google Doc. You can ask them even now. Leave them under the video, and I'll get back to you. You can also message our Facebook page with any questions, any topics you might want us to cover, maybe any types of videos. I've been thinking about doing some smaller videos about like answering some questions, like exam technique, or how to apply the knowledge, like the anatomy knowledge, in a exam scenario or a clinical scenario. So do let me know if that would be something you're interested in. Anyway, if there's no more questions, then I'll just end the stream. Thank you everyone for watching. I hope it has been helpful, and if it has, then do like it. Let us know that this is something you want, and we'll look forward to seeing you on the next live stream. It's going to be a weekly thing, so just put the topics you want and we'll get them done. Alright, good luck guys. Take care.